So today we'll be discussing about the vermiform appendix, which is the most common surgical emergency, and it is the most common cause of acute abdomen worldwide. So basically, and this is a very the surgery of the appendix is very easy, and it's the major surgery which is usually performed by the resident surgeon as his or her first surgery, right? So today we'll be talking about the vermiform appendix, the causes, the typical findings of acute appendicitis, and rest of the things. So moving on to the vermiform appendix, the first thing we're going to discuss is about the surgical anatomy. So we all know that the basically first initially it was thought that it's a vestigial organ, but later on it was find out that it's not the vestigial organ. Instead, it is involved in the immune system, and because it's particularly involved, it's acting as a mucosal barrier. So it has something to do with your immune system. Plus, it's also very important to know that those patients who are suffering from ulcerative colitis, appendix actually is very protective against the ulcerative colitis. So all those patients who have their appendix being removed, they are more vulnerable in case of ulcerative colitis. But all those patients who are having their appendix with them, they did not undergo any appendectomy, they are particularly protective against ulcerative colitis. So talking about the surgical anatomy, you can see here in the picture that basically it is located in the right iliac fossa, and it's in the mesenteric border of the anti-mesenteric border of the cecum, right? You can see here this is the cecum, and the three tinea coli of the cecum, they meet each other and that's particularly the point where the three tinea coli of the cecum, they combine and they join each other. That's called as a confluence. So you can see here that this is the cecum, and the base of the appendix is particularly found out to be at the position of particularly to be at the position of the confluence of the tinea coli. So you can see here in this picture. So if we talk about the quadrants of the abdomen, we know that the abdomen has about like 9 quadrants in total, and basically the right iliac fossa is the place where you can locate the appendix. You can see here this is the rectum, then this is particularly the appendix. You can see here this is the tip of the appendix, this is the body of the appendix, and this is the base of the appendix, which is being attached to the confluence of the cecum. You can see here this is another image which is showing here the surgical anatomy. You can see here this is particularly the cecum, and these are the different variable position of the appendix. Now the thing is this, that there are a different position of the appendix. It can be retrocecal, that means it can lie behind the cecum. It can be prececal, that means it is lying just in front of the cecum. It can be paracecal, that means it's parallel to the cecum. It can be subcecal, that means that the appendix is lying below the cecum. And the fourth position, it can be pelvic. Just look at the diagram so that you can appreciate the different positions of the cecum. This is basically, you can see here, this is this particular position, this is called as prececal. It can be pre-ileal as well, but this is particularly prececal. You can see here this is going behind the cecum, so this is particularly retrocecal appendix. This is basically the subcecal appendix, and this is the pelvic cecum, which is going into the pelvic cavity. This is the subcecal, which is located to the inferior surface of the cecum. This is the posterior cecal, or you can see retrocecal, and this is the prececal. So the most common position of the appendix, in almost 74%, the position of the appendix is retrocecal. That means that lying behind the appendix, retrocecal, in cases of the retrocecal appendix, the typical signs of the acute appendicitis, they are not that much clear, because actually whenever the cecum is present in front of the appendix, cecum is distended with all the gases, and whenever you try to perform the superficial palpation, there is a hindrance between your hand and the appendix, because that's the different distended cecum which is present in between your hand and the tip of the appendix, right? So, but the most common position in case of the appendix is a retrocecal, and then we know other positions also, like the subcecal, paracecal, and pre-ileal and prececal. They're also we should keep in mind about the pelvic appendix as well, because sometimes we try to elicit the tenderness in the right iliac fossa, we try to elicit the tenderness or the rebound tenderness in the right iliac fossa, but there's no tenderness, because but ultimately it's found to have the acute appendicitis, because most of the time the appendix is retrocecal, so we can elicit the tenderness or the rebound tenderness. But in some cases where the appendix is pelvic or subcecal, it becomes difficult to elicit the tenderness in the right iliac fossa. So you can see here, pre-ileal is almost 1%, post-ileal is about 0.5%, pelvic is about 21%, subcecal is about 1.5%, paracecal is about 2%, and this is the retrocecal, which you can see here that this is about 74%. So most common is a retrocecal appendix, right? So you can see here, this is a laparoscopic view of the appendix. Whenever you try to put the laparoscope through the port you have made, you can see here, this is the cecum. And to the base of the cecum, you can see here to the tinea of the cecum. These are particularly called as the tinea calli of the cecum. And whenever these three tinea calli, they combine together and make a confluence, there you can find the base of the appendix. So you can see this is the base of the appendix. This hole is a large inflamed appendix. Usually the size of the appendix is 7.5 to 10 centimeter, but whenever the size is increased in more than that, greater than 10 centimeter, we can say that it is acute appendicitis. So this is basically the mesentery of the appendix, which is called as a mesoappendix. And we know that the mesoappendix, it's very much thin. As you can appreciate, that these are the vessels which are running in the mesoappendix. So most of the time this is the appendicular artery, and we know that the appendicular artery is a branch of posterior cecal artery, and posterior cecal artery is a branch of iliac artery. So you can see here that this is the base of the appendix, this is the body of the appendix, this is the tip of the appendix, and the base is attached to the cecum. And you can see here the mesoappendix, and you can see the appendicular artery, which is running just in between the mesoappendix. But sometimes we know that there is only one appendicular artery which is supplying the appendix, and I already told you that appendicular artery is a branch of posterior cecal artery, which is a branch of iliac artery. But sometimes there is another artery which is called a accessory appendicular artery, and usually it lies close to the base of the appendix, right? So whenever you are ligating or you're performing the appendectomy, you have to ligate the mesoappendix, and then you have to ligate the base of the appendix. These two things should be ligated very nicely, so that there should not be any bleeding or hematoma formation later on. So you can, so we just talk about the surgical anatomy of the appendix. So we're going to talk about the microscopic anatomy of the appendix. This is basically the histopathological section, or which is showing the microscopic anatomy. You can see here, this is the lumen of the appendix, and you can, basically the appendix has 4 layers, mucosa, submucosa, and a muscularis mucosa, muscularis layer, and then you have the subserosal layer. So you can see here that the fold of the mucus folds, you can see just around in the periphery, they're the folds which are surrounding the lumen of the appendix. Plus there are a lot of lymphoid tissue which is located in the submucosa, right? So what happens is whenever there is acute appendicitis, or there's acute inflammation of the appendix, what happens is that there is lymphoid hyperplasia, and we know that the lymphoid tissue, they are mostly located in the submucosa, and whenever the lymphoid hyperplasia is there, that further obstruct the lumen of the appendix, and whenever the lumen of the appendix is obstructed, there is mucus secretion, there is a stasis, there is a bacterial seeding, and then what happens that if the lumen gradually goes on getting narrow, then what happens that there is gangrene ultimately, and then what happened that the appendix get perforated, and this perforation lead to peritonitis as well. So this is basically the sequel, which is starting from the bacterial or the viral infection leading to the obstruction to the lumen, and lymphoid hyperplasia leading to the obstruction of the lumen. And when there is luminal obstruction, that particularly leads to the luminal obstruction that leads to the gangrene and ultimately the perforation of the appendix. And whenever the appendix is perforated, that lead to peritonitis. So let's just talk about the acute appendicitis first. Then we're going to talk about some tumors which are located in the located in the premises of the appendix, or which are involving structurally the appendix, right? And then we're also going to talk about the pseudomyxoma peritonei. But first of all, we're going to talk about the acute appendicitis. Already told you that this is the cecum, and you can see here the tip of the appendix, the body of the appendix, and the base of the appendix that is attached to the cecum. And you can see here the red color is showing you the inflammation. So there are multiple theories which are trying to explain the pathophysiology behind the acute appendicitis, but they're just the theories. There's no proven hypothesis, right? So I'll be sharing some of the theories with you, like some studies suggest that there can be a Faecolith, which is also called as appendicolith. That is basically the part of a little small part of the stool that is called as a Faecolith. So what happens is, usually we know that appendix is a blind loop, right? And it is closed from that side. It has a very small, narrow lumen, and we know that the stool, after the absorption in the ileum, that comes to the cecum and goes to the descending colon, and then to the after passing through the colon, that goes to the rectum, and from the rectum it goes to the anal canal, and passing through the anal canal goes to the anus, and that's how we excrete the excreting material. But what happens sometimes that whenever there is there's some kind of stool impaction in the cecum, some of the Faecolith comes here into the appendix, and because it's a blind-ended tube and it has a very narrow lumen, so what happens that actually it leads to the infection and the inflammation, and obviously whenever there's a Faecolith or there's lymphoid hyperplasia that lead to the luminal obstruction. The luminal obstruction lead to stasis, and there's a lot of mucus secretion. And whenever there is a lot of mucus secretion, there is a seeding of the bacteria, and all these things lead to the formation of the appendicitis, right? But sometimes the inflammation is contained, so that would be appendicitis. But sometimes that appendicitis that lead to the formation of the abscess, because there's a penetration of the neutrophils, and that infection or the inflammation that is converted into abscess, which is basically the contained infection, right? But and the patient, whenever the patient has a appendicular abscess, that abscess is mostly over the iliopsoas muscle, and that abscess lead to the toxic look of the patient, and the patient is tachycardic, patient is very much febrile, and patient is tachypneic as well. Plus, what happens is that sometimes because of the luminal obstruction, because of the inflammation, ongoing inflammation, what happens is there is gangrene, and ultimately we know that whenever there is a gangrene, there will be perforation of that particular organ. So that leads to the appendicular perforation, and we know that whenever any viscous is getting perforated into the peritoneum, that leads to the generalized peritonitis. So most of the time, whenever there is a appendicular abscess, what happens is most of the time appendicular abscess doesn't perforate. So because the pus or the infection that is contained in a cavity, so that's, you can say, a protective mechanism which is provided by the nature, right? But sometimes what happens is that whenever there's acute appendicitis, but there's no formation of the appendicular abscess, and the infection goes on adding day by day, and the infection is not resolved. So what happens is that leads to the gangrene and the perforation, and that leading to the generalized peritonitis. Okay, so regarding the risk factors of the acute appendicitis, we'll be discussing the risk factors one by one. First of all, one is the extreme of the age, the other is immunosuppression. The third is a diabetes mellitus, which is basically also causing the immunosuppression, Faecolith obstruction, and pelvic appendix. Now, what do you mean by the extremes of the age? That means that usually it's not common in the children. Acute appendicitis is not common in the children. It usually involves the young adults and the teenagers. So you can say that the acute appendicitis, it is the infection of the teenagers and the young adults. So extremes of the ages, like the children or the older adults, they do not have the acute appendicitis. So keep two age groups in your mind. One is the teenagers and the other is the young adults. And let me tell you that in male population, it's more common as compared to the female population. The second thing regarding the risk factors for the acute appendicitis is the immunosuppression. So what do you mean by the immunosuppression? That means that we know that there are a number of diseases, like autoimmune diseases particularly, which is causing the immune suppression, right? Most of the time, like the autoimmune diseases, like we know that a number of autoimmune diseases like SLE, that systemic lupus erythematosus, that is an immunocompromised or immunosuppressed disease. Infection, other infective causes includes HIV/AIDS, which is also an immunosuppressive group for the acute appendicitis. So another cause or another risk factor for the acute appendicitis is the diabetes mellitus, right? Diabetes is the most common entity worldwide. So what happens, we know that whenever there is uncontrolled diabetes, we know that the higher glycemic index that leads to the immunosuppression. So you can say that this immunosuppression and diabetes, they are interrelated to each other. And Faecolith obstruction. Now, I have already discussed about the Faecolith obstruction in the previous slides. By that we mean that the Faecolith is coming into the lumen of the appendix, is blocking the luminal portion of the appendix, and ultimately it's leading to the bacterial infection and more mucus secretion, and ultimately leading to gangrene and then perforation. And the pelvic appendix. Now, what a pelvic appendix has to do with acute appendicitis? We know that particularly in case of the in case of female, the female urethra is very small, and we know that almost the infections from the lower urinary tract, they ascend to the pelvic cavity. So basically the most common commensal in case of the urinary or genitourinary system is the E. coli. So most of the time what happens is like there is a seeding of that infection coming from the lower urinary tract infection, and then involving the acute appendicitis as well, which is located in the pelvic cavity. Now, most commonly, there is no particular organism involved in acute appendicitis. It can be viral, it can be bacterial. Most commonly is a viral organism involved at that, but we do not know the typical type of the organism involved. In case of the bacterial, it can be anaerobic as well, because we know that the gut flora is gram-negative anaerobes, and there can be aerobic as well as there can be anaerobic. But most commonly, you have to keep this thing in your mind. It can be viral, it can be bacterial. In case of the bacterial, it can be aerobic and anaerobic, or gram-negative organisms, which can be found out in case of the acute appendicitis. And there can be previous abdominal surgery. How come the previous abdominal surgery is related to the acute appendicitis, presentation of the acute appendicitis? Because we know that there is a risk of infection in case of the acute abdominal surgery. Plus there's also immunosuppression, because whenever you're undergoing the surgery, you're exposing your interior of the body to the exterior atmospheric environment. So what happens is you are exposed to the external atmosphere, and that can lead to the internal infection in the body. So this was about the risk factors. Let's just talk about the pathology. I have already discussed in the previous slide a little bit about that. It can be viral, it can be bacterial. There is no particular organism which can be isolated, but usually it's viral, and in case of the bacterial, they can be gram-negative and anaerobic organisms. So whenever we are dealing with acute appendicitis, we have to give a cover of third generation cephalosporins, gram-negative cover, and we have to give the metronidazole, the flagell, which is basically the anaerobic and gram-negative cover. So you can see here, this is basically the pathological segment. This is the lumen, and this is I have already discussed in the previous slide that it has 4-layer mucosa, submucosa, muscularis, and then the internal most layer is the serosa, right? So you can see here that this is a lumen, and whenever in the submucosa, you can see this is submucosa, and these are the glands. These are the lymphoid glands which are located in the submucosa. So whenever there is acute appendicitis, there's infection, there's inflammation, there is lymphoid hyperplasia, and that particular lymphoid hyperplasia keep on adding, and it keep on narrowing the lumen of the appendix, and that will lead to further deterioration of the condition. So how come a patient will present to you with all these signs? First of all, we know that the pain, right? And most of the time in the early stages, the pain starts from the central abdomen, para-umbilical region, right? And then later on, it is shifted into the right iliac fossa. So this is also called as a migrating sign. That means the pain started. The patient will typically tell you that the pain started in the central abdomen, and then after a day, it got migrated to the right iliac fossa. The pain in the central abdomen has gone, and now it is localized to the right iliac fossa. And the patient will tell about the pain in the right iliac fossa. There will be symptoms of nausea, vomiting, right? And the patient can tell you about that he feels febrile as well, because it's an infection. So some patients report to you with a febrile illness, and particularly if the patient has a pendicular abscess, that appendicitis has converted to the pendicular abscess. So in case of the pendicular abscess, the patient would be febrile, the patient would be tachycardic and tachypneic as well. So nausea, periumbilical colic, pyrexia, localized pain, anorexia, pain shifting to the right iliac fossa, and the rebound tenderness. These are particularly the signs we have to elicit in a patient who is coming to you with right iliac fossa pain, right? So what is the typical scenario? A young male or female, but more commonly male, a young male or a teenager, adult, young adult coming to you with a pain which started in the central abdomen, and after a day it got localized to the right iliac fossa with the complaints of nausea, vomiting, anorexia, plus there can be pyrexia, there can be periumbilical colics, right? So what you suspect in case of a male, you suspect the first thing that comes in your mind is acute appendicitis, but in case of female patient, there can be ovarian torsion because we know that right ovary is also extending to the right iliac fossa. So the ovarian torsion or ovarian cyst, rupture ovarian cyst, these all also present as differential for the right iliac fossa. So you have to keep that thing in your mind as well. So this was about the clinical symptoms. We're going to talk about the signs. First of all, what you're going to do is you're going to examine the abdomen of the patient, start from the inspection, the breathing pattern, the inspection, then you have to palpate the whole of the abdomen, starting from the superficial palpation, going down to the deep palpation. You have to examine the abdomen in quadrants, and whenever the patient is pointing you to the right iliac fossa, you do the superficial palpation and then you do the deep palpation, and sometimes there's a tenderness tenderness at the superficial palpation, and then the deep palpation at the tenderness at the deep palpation, right? So first of all, tenderness in the right iliac fossa, first sign. Rebound tenderness is the second sign. Now, what do you mean by the rebound tenderness? Rebound tenderness, that means that whenever you push your hand on the right iliac fossa, you elicit the tenderness, but whenever there is no pain whenever you push the abdomen or the right iliac fossa with the palp of your fingers. But whenever you lift your fingers up, the patient shouts like anything. So this is because of the pain. And actually, what's the mechanism behind this? The mechanism is that the visceral peritoneum that touches the parietal peritoneum, and we know that the visceral peritoneum, that is not sensitive to pain, but the parietal peritoneum is sensitive to pain. So whenever you are pushing down, there's no pain, but whenever you lift your finger, the visceral peritoneum come back to strike the parietal peritoneum, and we know that the parietal peritoneum is sensitive to touch, so the patient feels the pain. So tenderness is a one point, rebound tenderness is a second point, and there are 4 other signs we need to elicit in a patient who is coming to you with acute appendicitis. Pointing sign, Rovsing sign, soft sign, and obturator sign. So what is the pointing sign? Pointing sign is that typically the patient will point to you that I've got a pain at the right iliac fossa. So he'll point to the right iliac fossa. This is called as a pointing sign. The other is a Rovsing sign. In case of the Rovsing sign, what you do is you try to elicit, you palpate the left iliac fossa, and the patient says that I've got a pain in the right iliac fossa. You can see here whenever you push the left iliac fossa, this travels right here from to the appendix, right? So what happens that whenever you push the left iliac fossa, the gas or the contents, they're pushed backward from descending colon to transverse, then ascending, and it goes down to the cecum, and they strike the inflamed appendix. So whenever they strike the inflamed appendix, the patient complains of pain. So what you do in a Rovsing sign, you push or you do a deep palpation at the deep palpation at the left iliac fossa, and then the patient says that I have got a pain in the right iliac fossa. The other sign is a Psoas sign. Now, Psoas sign, we know that the appendix is just located above the iliopsoas muscle. So in case of the Psoas sign, particularly for the retrocecal appendix, in which we know that the appendix is located posterior to the cecum or behind the cecum, well, this is a sign which is called as the Psoas sign. In Psoas sign, what you do is you ask the patient to turn left, right? To turn on a left lateral position, and then you extend the hip and you extend the knee joint as well. That means that the whole of the leg is extended, and then you try to abduct the leg externally. You can see here in the picture that you hold the leg from the thigh, and then you try to move it away from the body. That means that you are doing the abduction, right? So whenever you perform this test, the patient says that I have a pain in the right iliac fossa. So this is called as a Psoas sign, and it is particularly indicated for the retrocecal appendix. There is another sign which is called the Obturator sign. In case of the Obturator sign, what you do is that you ask the patient to lie in a supine position. You flex the knee, right? You flex the knee joint at the 90-degree, and then you internally rotate the knee joint. And whenever there's a flexion and internal rotation of the knee joint, there is a pain. This is called as obturator sign. So these are the 4 signs. There are other signs as well, but commonly these 4 signs are used in case of the patient who is coming to you with right iliac fossa pain to exclude the diagnosis of the acute appendicitis. One is a pointing sign. The patient will point to you that I've got a pain in the right iliac fossa. The second sign is a Rovsing sign. You do the deep palpation at the left iliac fossa, and the patient says that I've got a pain in the right iliac fossa. This is called as a Rovsing sign. The other sign is called as a Psoas sign, in which you ask the patient to adopt a lateral position and ask the patient to extend the leg, and then you try you hold the leg through the thigh, and then you try to abduct it. So whenever there's an abduction, there's a stretching of the psoas muscle, and the inflamed appendix touches the psoas, and that leads to the tenderness in the right iliac fossa, or the pain in the right iliac fossa. So that you can appreciate that the thing which comes in your mind is a retrocecal appendix. And then you have the obturator sign, in which you ask the patient to lie in a supine position. You ask the patient to flex the knee at 90-degree, and then you try to internally flex and internally rotate. On internal rotation of flexion of the knee, there is a pain in the right iliac fossa. So these signs are very important: rebound tenderness, pointer sign, Rovsing sign, Psoas sign, and obturator sign. So you have to elicit all these signs. So features according to position, I have already discussed about the different variation and the position of the appendix, and I believe that few or the symptoms are related to the positioning of the appendix. So we know that the most common position is the retrocecal appendix, and that's about 74%. And in case of the retrocecal appendix, the rigidity is absent. Why the rigidity is absent? Because I've already told you that the appendix is lying behind the cecum, and most of the time the cecum is distended with the gases, and whenever you try to do the superficial palpation, there is hindrance between your hand and the appendix, and there is no tenderness. But there can be deep tenderness in the loin. Rigidity is absent, deep tenderness in the loin, and there can be rigidity of quadratus lumborum, or there can be zoospasm. I've already told you that we elicit the Psoas sign in case of the retrocecal appendix. Or, whenever you do the hyperextension of the joint that causes the pain, which is particularly we do in the obturator sign. In case of the pre-ileal, because it's, the appendix is just in front of the ileum, so there can be early diarrhea, there's absence of rigidity, there is tenderness over the McBurney's, particularly, that the McBurney is a point starting from the anterior superior iliac spine to the symphysis pubis, right? So it's a midway between 2/3 and 1/3. So it's a midway, it's a quarter way between that line, which is starting from the anterior superior iliac spine to the symphysis pubis. So the tenderness over McBurney is typical in case of the acute appendicitis, particularly in case of the retrocecal appendix. But in case of pre-LL, it's absent, spasm of the psoas, and obturator, the obturator internus muscle that can also be present. There can be increased frequency of micturition. In case of the post-allele, there would be diarrhea, there would be marked retching, and the tenderness would be ill-defined. So you have to keep all these things in your mind. So patient coming to you with a pain in the right iliac fossa, what you're going to think about, what would be your differential diagnosis. In case of children, what you have to think. In case of adult men, what you have to think. In case of adult female and old age group, what you have to do. So a patient is coming to you with nausea, vomiting, anorexia, and the age is about like 5-6 years, and there is a tenderness in the right iliac fossa. So it can be gastroenteritis, it can be mesenteric adenitis, which is very much common in case of the children. It can be Michel's diverticulum, which is also located in the right iliac fossa to the antimesenteric border of the cecum, right? And there can be intussusception, or there can be henoxylin purpura. So these are the differential diagnoses in case of children. In case of children, and there can be lobar pneumonia. In case of young male, you can think about the regional enteritis, you can think about the uretary colic, you can think about the perforated peptic ulcer. You can think about the torsion of the testes, you can think about the pancreatitis, or you can think about the rectus sheath hematoma. So in case of female, it can be Mittelschmerz, it can be pelvic inflammatory disease, it can be pyelonephritis, it can be ectopic pregnancy, it can be torsion or rupture of the ovarian cyst, or it can be endometriosis. And in case of males, usually you think about the advanced diseases like the diverticulosis, diverticulitis or diverticulosis, intestinal obstruction, colonic carcinoma, torsion, appendix epiploic, or mesenteric infection, or leaking aortic aneurysm. So all these things you have to keep in your mind. In case of children, what you have to think that it can be mesenteric adenitis, it can be gastroenteritis, it can be Michel's diverticulitis, it can be intussusception, henoxylin purpura, or it can be lobar pneumonia. In case of the adults male, you have to think about the regional enteritis, you have to think about the torsion of the testes, perforated peptic ulcer, uretary colic, pancreatitis, or rectus sheath hematoma. In case of young female, you have to think about other structures like the Mittelschmerz, which is basically the cyclical pains, and there can be pelvic inflammatory disease, torsion of the ovaries, or there can be ruptured variances, there can be ectopic pregnancy. So whenever you are ordering the investigation, particularly in case of females, you have to do the urinary pregnancy test as well. For the ectopic pregnancy, there can be endometriosis. So in case of the old patients, you have to think about other diseases like the diverticulitis, diverticulosis, or you can also think about the intestinal obstruction, colonic carcinoma. You can think about the mesenteric infarction, and you can also think about the leaking aortic aneurysm as well. And investigation, coming to the most important step or in the diagnosis and reaching the surgery of the appendix, the thing is investigation. You have to properly investigate. The most important investigation in case of the acute appendicitis, obviously, because sometimes ultrasound is not very much helpful. So starting from the non-invasive baseline investigation, you have to order all the baseline investigation like full blood count. You'll order for the urine RE, because sometimes there can be urinary tract infection which can present like the lumbar or the iliac fossa pain, right? So you have to order for the blood CP, serum electrolytes, RFTs, LFTs, the routine test, urine RE, ESR, CRP, and then you have to go for the ultrasonography. And if the ultrasonography doesn't tell you about the free fluid, because it won't, sometimes the appendix is not visible, a normal appendix is not visible, but sometimes they will tell you that there's a free fluid. So the indication for the free fluid is they sometimes they can tell you that the probe tenderness is positive in the right iliac fossa, or sometimes they can tell you about the sometimes you dilated loop of the appendix can be visible in the ultrasound, and sometimes they can tell about the free fluid in the right iliac fossa. So particularly in ultrasound, you have to think about all these things. So investigations include the routine full blood count, urine analysis, selective pregnancy test in case of the females, because it can be ectopic pregnancy, urea and electrolytes indicating there is no problem to the kidneys, supine abdominal radiograph. Why supine abdominal radiograph? Because if you're suspecting the perforation, right? So there can be, in case of supine abdominal radiograph, there can be gut distension, but in case of erect abdominal distension, you can find out the air fluid levels. And then you have to go for the ultrasound of the abdomen or pelvis. And the gold standard for the appendicitis is a CT scan, which is contrast enhanced abdomen and pelvic CT scan. So signs, you can there is particularly, you can say that there is particularly a scoring system which is called as the Mantrils, and or which is Alvarado scoring system. So it is starting from M stands for migrating right iliac fossa pain, A stands for anorexia, N stands for nausea, and we have given a scoring of 1 to the migratory right iliac fossa. Migratory right iliac fossa pain, that means the pain started in the central abdomen and then it got shifted to the right iliac fossa. So it has got a score of 1. Anorexia is 1, nausea is 1, tenderness in the right iliac fossa, rebound tenderness, and elevated temperature. Tenderness is 2, rebound tenderness is 1, and elevated temperature is also 1. So this was about the Mantrils, and L stands for the leukocytosis, and we give a score of 2 to the leukocytosis, and shift to left, that means there is more neutrophilic count and immature neutrophils are more common, which is showing the infection. So leukocytosis is 2 and shift to left is 1, and the total counts are to be 10. So let me repeat that the Mantrils, we calculate in the patient we are suspecting the acute appendicitis, and depending upon the symptom signs, the laboratory investigation. So migratory right iliac fossa pain, M stands for migratory right iliac fossa pain, anorexia, A is for anorexia, N is for nausea, and 111 is the scoring for all the 3 things. Then you have the tenderness, T stands for tenderness, R stands for rebound tenderness, and E stands for elevated temperature, L stands for leukocytosis, and S stands for shift to left. So the tenderness has got a score of 2, and leukocytosis has got a score of 2. Rest of all the parameters, they got a score of 1. So the total score is 10. Score at 6 or above 6. Like if the score is 5 or 6, that means that you have to go for the CT scan to further investigate. A score of greater than 6 or 7, there's a definitive appendicitis. And a score less than 5, like that means least likely, very least likely. So this is called as Alvarado scoring system, and you have to calculate the Mantrils. So regarding the investigation, this is the ultrasound. You can see here, this is the whole of this is the free fluid here, and this is the loop of the appendix. You can see here, this is the tip of the appendix, the body of the appendix, and the base of the appendix. But sometimes This is a very nice ultrasound which is showing you actually the blind loop, but sometimes if the caliber of the or the diameter of the appendix, we know that it's like 7.5 to 10 centimeter, right? So sometimes it's not visible. Sometimes they say that it's only the probe tenderness or there's free fluid in the right iliac fossa. The gold standard for the acute appendicitis is the CT scan abdomen. You can see here in the CT scan, this is the cecum, and from the base of the appendix is attaching to the cecum, and this is the dilated loop which is being seen in the right iliac fossa. So this is about the investigation. Now you have to go for the non-operative management, right? So the non-operative management starts from giving the bowel rest. You have to NPO the patient, and then you have to put the patient on antibiotic regime. Like you have to give the good painkillers, and then you have also you have to give the fluid as well, because you are giving the bowel rest. So you have to give 3 liters of fluid in 24 hours to the patient, and you have to start from the third generation cephalosporin, meropenem, or the combination of some good anaerobic and gram-negative cover, which is Flagyl, which is the metronidazole. So intravenous antibiotics includes metronidazole, the generation cephalosporin, and ertapenem. So non-operative management includes the bowel rest and the intravenous antibiotic plus the good hydration as well. And hydration includes, like, you can add ringers or 5% dextrose, like combining 3 liters of fluid in 24 hours. So regarding the conventional appendectomy, there are 2 incisions most commonly, which are most commonly used for the appendectomy. Conventional appendectomy is the open appendectomy. So this is the anterior superior iliac spine, and this is the umbilicus. So what you do is that you actually divide this 2/3 and this 1/3. So 1/3 is close to the anterior superior iliac spine and 2/3 is close to this umbilicus. So this incision is called as the Rutherford-Morrison incision or McBurney's incision, because you're giving the incision at the McBurney's point. So already told you that starting from the anterior superior iliac spine to the umbilicus, and then you divide it 1/3 to 2/3, and then you give incision here at the McBurney's point. So this is called as a McBurney's incision, or called as a Rutherford-Morrison incision. There's another incision which is called as a Lane's incision. And in case of Lane's incision, the landmarks are anterior superior iliac spine and the pubic tubercle or symphysis pubis. So what you do is you get a mid-inguinal point, right? This is the, this was a McBurney's point, 1/3, 2/3 between the anterior superior iliac spine and the umbilicus, and the other one is anterior superior iliac spine at the pubic tubercle, and the midway is the inguinal ligament. So you keep a distance of like 2 centimeters from the umbilicus, and this is called as Lanz incision. So these are the 2 incisions. One is a Rutherford-Morrison incision here at the McBurney's point, and usually it's a big incision, but the Lanz is more cosmetically favored, and that's actually a transverse incision. This is an oblique incision, so it's a transverse incision. So Rutherford-Morrison and McBurney's incision, and the other is a Lanz incision. So how you actually do the appendicectomy, starting from a point, you give the incision. It's your choice whether you give the Lanz incision or you give the Rutherford-Morrison incision, right? But in case of, because Lanz is it's more cosmetic incision. So whenever you are performing a surgery, in case of young female or young male, in which they're more concerned about the cosmesis, so always take care of these things that give the Lanz incision, because it's a transverse incision and it's not that much big incision, so it's cosmetically a better incision, the better incision as the Lanz incision. So what we do that we open the abdomen, and then we divide, you give the incision, you cut it, and then internally we have the skin, the subcutaneous tissue, and then you have the fat, and then you have the layers of the muscles. First of all, you have the external oblique aponeurosis. You give a small nick at the external oblique aponeurosis, you open the external oblique aponeurosis, it goes deep down, right? And just beneath the external oblique aponeurosis, you have the internal oblique. You split the internal oblique in the direction of the fibers of the internal oblique, and then you go down to the deep down to the transversalis muscle, which is basically the transversus abdominis muscle. So you split the transversus abdominis as well, and then you go deep down to the transversalis fascia, and then you open the peritoneum. And whenever the peritoneum is open, you usually, most of the time, you have the cecum in front of you, you trace the tinea, you go to the confluence of the tinea, you find out the base of the appendix, then you ligate the base of the appendix, you ligate the mesoappendix with the appendicular artery, and then you separate the appendix, and the appendix is removed from the bed, and then obviously the hemostasis is secured, and then you again close the abdomen in layers. So you give the skin incision, then you have the external oblique aponeurosis, you give a nick in the external oblique aponeurosis, you goes deep down, you split the internal oblique in the direction of the fibers, you split the transversus abdominis muscle, and most of the time the transversalis fascia is close to it's adjacent to the peritoneum. You open the peritoneum, and then just going down to the peritoneum, there is the cecum in front of you. You find out the tinea, base of the appendix. You ligate the base, you ligate the mesoappendix, and then obviously you remove the appendix, and then you secure the hemostasis, and then ultimately what you do is that you close the abdomen in layers. Okay, so there are a few methods which you have to follow in case of special circumstances, like in case of if the cecal wall is edematous or the base of the appendix is inflamed. So what you have to do is, like, most of the time we do the open appendectomy, but sometimes in special circumstances there is edematous cecal wall, so you have to ligate the base of the appendix very, very carefully so that you do not injure the cecum, because whenever the tissue is edematous, it's very friable, it's very fragile, so you have to keep that thing in your mind. So there is another category which is called as retrograde appendectomy. So most of the time we do this retrograde appendectomy in case of the retrocecal appendix. Like this is the normally the appendix lies here, but in case of the retrograde appendicectomy, you ligate, this was the first knot you're taking, but you're not taking the knot very close to the, you're not tying the base of the appendix. You have to be very close to the cecum in case of the retrograde appendectomy. Like in case of what you do is you go behind the cecum and then you tie the knot just close to the cecum, right? Because sometimes this is the anterior aspect of the this was the anterior aspect, so this is the more medial aspect. So whenever you open the peritoneum, this part of the cecum is visible to you, but sometimes we know that the appendix is retrocecum, so we have to perform the retrograde appendectomy. We have to go behind the cecum and we have to take the knot close to the cecum, just the base of the appendix is tied there. So this is the retrograde appendectomy, and in case of the retrocecal appendix, we do this retrograde appendectomy. So in case of the laparoscopic appendectomy, let me tell you that laparoscopic appendectomy is the most common procedure, because open appendectomy, that was a conventional procedure and it was used to be performed in the previous arise. But now with the recent advances, most of the time the people are more comfortable with the laparoscopic appendectomy, because cosmetically laparoscopic appendectomy, especially for the young females or the young males, this is very much helpful for the cosmesis. So what you do is one is the infraumbilical port, one is umbilical, and one is a supraumbilical port. So you insert the camera, you insert the laparoscope, and then you visualize. But sometimes therapeutic laparoscopic appendicectomy is usually performed in the Western world, but in the South Asian belt, usually laparoscopic appendectomy is diagnostic, because sometimes you're not sure, the CT is not that helpful, or particularly in case of the female patient, you're unable to make the diagnosis, then you go for the diagnostic appendectomy. So this is how you do it. The ports are inserted, these are the graspers, and you just hold the base of the appendix, you tie it here, you cut it, and then the appendix is being removed, just depending on the laparoscopic appendectomy. So now it's very important to examine the wound and the abdomen, because there can be the abscess. You have to perform the rectal examination. You have to examine the lungs in case it can be pneumonitis or collapse. You have to examine the legs, because it can be deep vein thrombosis. And you have to examine the conjunctiva. There can be icteric tinge. You have to examine the liver for enlargement, and you have to examine the urine for pyelonephritis. So basically you have to rule out the differentials. That can be abscess, you have to examine the rectum as well. There can be pneumonitis, there can be collapse, there can be venous thrombosis, there can be icteric tinge, liver for enlargement, or there can be pyelonephritis, or you can suspect the subphrenic abscess as well. Post-operative complications in case of the appendicitis, there can be wound infection. This is the most common post-operative complication. There can be any intra-abdominal abscess, because sometimes when you're performing the appendicectomy and you do not ligate it, or the appendix is not fully removed, or there was already ongoing abscess on the source, so there can be intra-abdominal abscess. The patient can go into ileus. There can be venous thrombosis and embolism. There can be portal pyema, which is which is basically pyelophlebitis. There can be fecal fistula leakage, or there can be adhesive intestinal obstruction. So whenever you are performing the appendectomy, you have to give a good postoperative care, because all these postoperative complications take place, like the wound infection, intra-abdominal abscess, ileus, venous thrombosis, embolism, portal pyema, fecal fistula, adhesive intestinal obstruction. So you have to keep all these things in your mind. So about the recurrent acute appendicitis, sometimes the patient comes to you with a right iliac fossa pain, and you give the conventional antibiotics, the pain is relieved, and you manage the patient conservatively, but he again comes to you with the same symptoms. So this is called a recurrent acute appendicitis. So in sometimes a few patients doesn't want to go to undergo surgery. So what they do is actually they just ask you to put them on the conservative management, right? So what you do is, like in case of the conservative management, you put the patient on conservative management. He gets better, he feels better, and then he is discharged. But after 10 or 15 days, he comes back to you with the same symptoms. So that's called as a recurrent acute appendicitis. And in case of the recurrent acute appendicitis, you must undergo the patient appendectomy should be performed, whether the lap or open. It depends upon the surgeon and the patient. Now, this was about the acute appendicitis. We're going to talk about the different neoplasm of the appendix. Appendicular tumors, they're not very common, but the most common thing is a carcinoid tumor. But if we classify this neoplasm of the appendix, there are epithelial in origin, and there can be adenoma, which can be tubular or tubulovillous. There can be adenoma can have three classifications: tubular, villous, and tubulovillous. There can be a serrated polyp, there can be a non-mucinous adenocarcinoma, or there can be a mucinous neoplasm. So these are the classification for the epithelial neoplasms of the appendix, which are not very common. They are rare tumors. And the most common thing in case of the appendix is acute appendicitis. The tumors are very uncommon, but the most common tumor there are the carcinoid tumors, and the carcinoid can actually happen anywhere in the GI tract, but appendix is the most common location. But in case of those tumors which are originating from the epithelial neoplasia, you can have adenoma, which can be tubular, villous, or tubulovillous. It can be serrated polyp, it can be non-mucinous adenocarcinoma, or it can be mucinous neoplasm. So we divide the mucinous neoplasm into low-grade mucinous neoplasm and a high-grade mucinous neoplasm, and then you have the mucinous adenocarcinoma. So this is a little bit about the classification of the neoplasm, and we know that in case of the low-grade neoplasm, they do not invade or metastasize beyond the limits of the appendix. So if we perform the appendectomy with the removal of the lymph nodes and some part of the cecum, that's enough. But in case of the high-grade mucinous neoplasm, they metastasize, and whenever they metastasize, they cause the pseudomyxoma peritonei. And in case of pseudomyxoma peritonei, you have to go for the cytoreductive therapy, which involves the resection of the appendix and cecum and colon and intestine as well. So, this is kind of important. And there's another therapy which is heat, intraperitoneal heat induction therapy as well. So we can also give in case of. So there is another entity which is the adenocarcinoma with the signet ring cells less than 50%, and there's another entity which involves the adenocarcinoma, which is the signet ring cells greater than 50%. So you classify epithelial neoplasms in adenoma, serrated polyp, non-mucinous adenocarcinoma, mucinous neoplasms, and adenocarcinoma with the signet cell less than 50%, and the signet ring cells greater than 50%. And adenoma is further divided into tubular, tubulovillous, and the villous. And this category, which is the mucinous neoplasm, is divided into low-grade mucinous neoplasm and high-grade mucinous neoplasm, and then you have the mucinous adenocarcinoma. So what you do is the treatment for the case of the tumors. I told you in case of the low-grade tumors, you don't have to go for the hemicolectomy. But in case of the high-grade tumor, you go to perform the hemicolectomy with prophylactic regional peritonectomy. Because what happens is those tumors which are very much high-grade, they metastasize in whole of the peritoneum, and there is a tumor, you can say there metastasis to the peritoneal cavity, metastasis to the ovarian system. So you have to perform the hemicolectomy with the prophylactic peritonectomy. There can be a mentectomy because these tumor deposits, they involve the mentum as well. There's intraperitoneal chemotherapy, and you also perform the bilateral salpingo-oophorectomy. But this treatment is particularly for the high-grade neoplasms in which there is a pseudomyxoma peritonei. We'll discuss about the pseudomyxoma peritonei, but in case of low-grade tumor, surgery is limited. In case of high-grade tumors, surgery is extensive. So in case of high-grade tumors, we have to perform all this surgery, which involves the hemicolectomy, mentectomy, intraperitoneal chemotherapy, and the bilateral salpingo-oophorectomy. Now let's talk about the pseudomyxoma peritonei, which basically that means that it's not a true pseudomyxoma. That means that it's not true. Pseudo means false, right? So it's like most of the time, myxoma is a tumor of the muscles, right? So pseudomyxoma peritonei, that means that's a false muscular tumor of the peritoneum. Why we call it as a pseudomyxoma peritonei or false tumor? The reason is that most of the time, the high-grade neoplasms of the appendix, they metastasize, and there are tumor deposits which are involving the peritoneum, which are involving the ovarian cake, and they're also involving the mentum as well. That's why we need to go for the extensive surgery, which is the cytoreductive therapy, which involves the peritonectomy, bilateral self-plunger oophorectomy, appendectomy. So in case of that, we have to go for that. But let's just discuss about the classification of pseudomyxoma peritonei, which is basically acellular mucin, low-grade mucinous carcinoma peritonei, or there can be high-grade mucinous carcinoma peritonei, or there can be high-grade mucinous carcinoma peritonei with signet ring cells. Now, I told you that mostly, which is basically the acellular mucin, it doesn't metastasize, or there's no seeding. In case of the low grade, there's no seeding. You have to go for the appendectomy as well, and some regional lymph nodes are also resected. But in case of the high grade and high grade signal ring cells, you have to go for the extensive surgeries, and you have to go for the total peritonectomy. You have to go for the bilateral self-plunger oophorectomy, and you have to go for the mentectomy. Wherever the seeding of the tumor cells is there from the appendix, you have to perform that surgery. Now, morphologically, you can see here that this is basically the mental fat, and you can see the morphological appearance is so dirty, and there's a pus, and you can see that the tumor cells are invading into the peritoneal cavity. So this is basically the amentum, and this is the peritoneum, and whole is seeded with the tumor cells which are being invaded from the appendix. Plus, you can also appreciate this is in the CT scan. You can see here that there's a seeding of all this tumor deposits which are found in the ovaries, which are found in the peritoneum, in the mesentery, in the mentum, and there can be liver mets as well. So this whole of the entity is called as a pseudomyxoma peritonei. In case of the treatment for the pseudomyxoma peritonei, I already told you, in case of low grade, you just have to perform the partial peritonectomy. But in case of the high grade mucinous with the signet cell appearance, you have to go for cytoreductive therapy, which is combined with a heated intraperitoneal chemotherapy. So what involves the cytoreductive therapy? You're already cleaning everything, the segment of the colon, which is hemicolectomy, and self-plunger oophorectomy, and a mentectomy and peritonectomy. So this is the conventional treatment for the pseudomyxoma peritonei. So this was all about the topic of the appendix. We discussed about the acute appendicitis. We discussed about the most common thing is acute appendicitis, which we discussed in the detail, and we also discussed about the neoplasms of the appendix, and at the end we'll discuss about the pseudomyxoma peritonei. So this is all for today's lecture. Thank you for watching sqadia.com. Keep watching.